Good morning, and a warm welcome from Stanford Medicine. I was delighted to be invited to speak to you today for the opening of the second annual Stanford Conference on Disability in Healthcare and Medicine. In a very short time, the Stanford Medicine Abilities Coalition has made a profound impact on our entire organization, raising awareness and creating a robust community. Through the advocacy of Dr. Peter Poulos and others, Stanford Medicine revised our diversity statement to better reflect our commitment to the diversity in the disability community. The Stanford Medicine Abilities Coalition has become an official group of our diversity cabinet. SMAC continues to have a major impact beyond our institution by fostering a global community through events such as this. I want to congratulate and thank Dr. Poulos and SMAC for their important advocacy. Stanford Medicine embraces disability as a part of our mission to create a diverse, inclusive, and welcoming environment. SMAC is a vital part of this effort, sharing insights that help us achieve our tripartite mission in research, education, and patient care. Stanford Medicine seeks to create diverse, inclusive, and equitable environments. Not just because it's the right thing to do, we strive to cultivate this culture because it is responsible leadership and good science. We see time and time again how teams with diverse thought and backgrounds are more productive, more creative, and more innovative. As SMAC has shown, promoting diversity is not a passive activity, but one that requires action. Last year, in the wake of George Floyd's murder, Stanford Healthcare CEO David Entwistle, Stanford Children's Health CEO Paul King, and I committed to take a more direct and more aggressive steps against injustice and inequity. We launched the Stanford Medicine Commission on Justice and Equity and gave it a two-part mission. One, to examine our culture here at Stanford Medicine and identify concrete steps we can take to make it a more diverse, more inclusive, and more welcoming community. Two, we want to suggest strategies for how we as an academic medical center can bring about change nationwide. In a few minutes, Paul King will provide more details about the commission and its work. In many ways, the Stanford Medicine Abilities Coalition, this conference, and all of the participants today share the same goal as the commission, to bring about change where you are and beyond. I look forward to seeing and supporting the change that springs forth from these many efforts. Finally, I want to say that today you'll hear from the two other leaders of Stanford Medicine, David Entwistle, the President and CEO of Stanford Healthcare, and Paul King, the President and CEO of Stanford Children's Health. All of us in Stanford Medicine are tremendously fortunate to work with these truly outstanding healthcare leaders. They embody the very best of leadership, and they bring to our collective organization wisdom, expertise, dedication, and the type of values that we all want to represent to our community and to the world. It's now my great pleasure to introduce David Entwistle, the CEO of Stanford Healthcare. David?
Good morning. Thank you, Lloyd. I'm delighted to be here with you today. Stanford Medicine is fortunate to have providers with disabilities. The skills and insight these doctors, nurses, and staff, and students help our entire team to provide high-quality patient care. These providers are not only intelligent, warm, inclusive, compassionate, they're also crucial in making Stanford Medicine a preeminent academic medical center. We strongly support the Stanford Medicine Abilities Coalition's efforts to create an even more diverse and inclusive environment here and even around the world. The experiences and perspectives of those in our community with disability make us better at what we do. These providers can connect with patients emotionally and with humanity in unique ways. And they proactively identify challenges and offer advice that may not be top of mind for others. Oftentimes, they see the health system as both a clinician and a patient. Stanford Medicine and our patients deeply value this perspective. These benefits serve as yet another proof point for the need to have greater diversity among our healthcare workers, and the need for all healthcare workers to be more aware and sensitive to their patients' backgrounds. In the United States, people with disabilities are disproportionately affected by health challenges. We've seen this during the pandemic, but there are also many other examples. They have higher rates of preventable chronic conditions and early death. They are less likely to use preventative care. For example, there's a higher prevalence of smoking-related cancers, and women with disabilities are less likely to have regular mammograms. People with disabilities are also more likely to have unmet health needs. As we continue our focus on advancing health equity, as will be talked about in the work that the Commission's doing, addressing these disparities remains an important part of our effort. As an organization, the more we can represent the patients that we serve and connect to their needs, the better we will be at lifting the health of all people in all of our communities. Before I hand it over to my colleague, Paul King, the CEO of Stanford Children's Health, I would like to also thank the organizers and everyone here that's attending today for their commitment and advocacy. I firmly believe that we can create a more inclusive healthcare system through the sustained efforts of people like you and events like these. Paul?
Thank you, David. And I'd like to thank the conference co-chairs, Dr. Peter Poulos and Zainab Danani, for inviting us to speak and for their hard work producing this conference. A disability is not a problem to be solved. It's a trait to be valued. It's a characteristic to be recruited, supported, and included. This gets to the very essence of diversity. And as Lloyd and David said, we value it on an organizational level for a number of reasons. Greater diversity among faculty, students, and staff increases a sense of belonging. Numerous studies have shown how diverse organizations perform better than those that are less diverse. This makes perfect sense. Teams can't coalesce as effective units if every member isn't allowed to participate, or if a member isn't confident that their contributions will be accepted. The modern hospital, indeed our entire complex healthcare system, is built on teamwork. This fact was made quite evident during the early weeks of the pandemic as we dealt with PPE shortages and developed infection control procedures to protect our environmental and food service employees and supported our frontline healthcare workers. We succeeded when our team succeeded. We succeeded because our diverse team succeeded. I also appreciate the importance of building community, particularly how it helps individuals foster their own respect and pride, and how important it is to share it with the broader organization. Diversity is also critical to patient care. As David just mentioned, diversity of abilities among our care team is vital so that we can better connect with our patients about their conditions, treatments, and prognoses, and address their needs. Lloyd mentioned that Stanford Medicine launched the Commission on Justice and Equity last summer. I'd like to share more about this important initiative and share just a bit about their work. The Commission on Justice and Equity is made up of internal and external leaders who are advocates and experts in social justice and diversity. We're fortunate that Rosalind Hudnell agreed to chair the commission. She's the former vice president of global corporate affairs at Intel and president of the Intel Foundation. She brings a wealth of experience in change management and diversity initiatives. The commission has met numerous groups and individuals at Stanford. I know they greatly benefited from meeting with the Stanford Medicine's Ability Coalition. In addition, an organization-wide survey was conducted aimed to assess where we stand on diversity and inclusion and how we can improve. This survey was an important part of the Commission's work so that its members could hear directly from all stakeholders, including faculty, students, and staff with disabilities. We anticipate that the Commission's final report will make recommendations for how we can affect change on our campuses, in our hospitals, and more broadly in our country. The Commission's work is important, but it's just one piece of what must be sustained, what must be a sustained community-wide effort to promote diversity and inclusion. This is what brings us here today. I join David and Lloyd in thanking all of you for your part in raising awareness and creating a more welcoming environment for people with disabilities. We hope you enjoyed today's conference, and now I turn it over to Zainab.
Thank you for your remarks, Dean Miner, Dr. Entwistle, and Dr. King. Good morning, everyone. Thank you for joining us today for the second annual Stanford Conference on Disability in Healthcare and Medicine, hosted by the Stanford Medicine Abilities Coalition and medical students with disability and chronic illness. My name is Danani, and I am a medical student and a health policy master's student at Stanford School of Medicine, a member of Stanford's Medical Students with Disability and Chronic Illness, and the founder and co-chair of today's conference. We are thrilled that you could join us today and are excited to provide you with a schedule jam-packed with education. Next slide. We're going from 8 a.m. to 4:30 p.m. Pacific Standard Time with 4 speaker sessions and 2 breakout sessions today. The content will end at 4:30 p.m. and our happy hour starts at that time. We've got 5 breaks throughout the day, including an hour break at lunch. To keep the conference interactive throughout the day, we will be using Slido, which can be used for discussions, comments, networking, and questions. You can find the Slido chat function on the right side of your video feed or at slido.com with event code SMAC 2021. This conference was founded with the mission of advancing the conversation around disability in healthcare, from providers to trainees to patients. As a medical student, I have been inspired and uplifted by the disability initiatives here at Stanford, and excited to share that same spirit throughout our programming today. Next slide. CME credit is also available for today's conference. Please see in the email or our website for further information. Next slide. Looking at this year's conference, it was built not only based on what we believe to be topics of great interest and importance, but also the feedback from last year. We took your suggestions and made this conference more diverse, more practical, more interactive, included more breaks, and added a heavily requested session on disability law. We also believe it's important to let you know where we and many of you in the audience stand in our understanding of diversity, disability, and medicine. We will start with the following assumptions. Diversity is important. Disability is a component of diversity. Disabled people have equal value to non-disabled people. Doctors with disabilities are underrepresented in medicine. And doctors with disabilities have a unique and valuable role to play, understanding the experiences of both patients and providers. I'd like to now introduce you all to my co-chair for today's conference, Dr. Peter Poulos. Dr. Poulos is a clinical associate professor of radiology. He is the founder and executive director of the Stanford Medicine Abilities Coalition, which he founded in 2018, and the faculty advisor of medical students with disability and chronic illness. I would like to now turn over the mic to Dr. Poulos, who will also be sharing some opening remarks.
Thank you, Zainab, for that kind introduction, and welcome everybody to today's conference. So why are we here today? The ADA was passed in 1990. Why are we still talking about disability? Why are 1,000 people tuning in on a Saturday to talk about things that they work on in their day jobs? The Coalition Symposium for Disability Access in Health Science Education was held earlier this week, but here we are again. So what are we up against? This is how I got involved, and one of the reasons that I'm here. I'm also a doctor with a disability. I had a cervical spinal cord injury in 2003, and I'm a C3-4 incomplete quadriplegic. This happened when I was a GI fellow at UCSF, and after my rehabilitation, I switched careers to become a radiologist. So I'm going to ask you again, why are we here and what are we up against? I showed this slide last year and it seemed to resonate with the audience. There's a culture of strength in medicine, especially in med schools and residency programs. Doctors are expected to tolerate pain beyond that of most other professions. We're expected to work extremely long shifts without complaining. We're trained not to ask for anything, to be fast and efficient. We're not given enough time for self-care, and we're proud of it. This can all lead to burnout, suicide, and all of the other ails that we know are associated with being a doctor. But it's important to be precise, and strength itself is not our enemy. We have to call our enemy by its name, and that name is ableism. Ableism is, according to Wikipedia, discrimination and social prejudice against people with disabilities and/or people who are perceived to be disabled. It also relates to the idea that disability is a defining character flaw and that people are defined by their disabilities. It's an insidious belief system that permeates the healthcare system, and it must be torn out by the roots. Ableism creates a binary between the disabled and non-disabled, creating two distinct groups, one desirable and the other not. One is stigmatized and the other is celebrated. But I say that this is a false binary and actually a very harmful fallacy. Disability is equated with inability. But when you analyze this, the idea is nonsensical. Some people describe ability as a spectrum, but this is also an imperfect way of conceptualizing it. Let's take an example. So thinking about physical ability, here we see a quite physically disabled man, Stephen Hawking, on the left. And I would say a very able LeBron James of the LA Lakers, one of the greatest basketball players of all time. These extremes are relatively easy to conceptualize, but where do I fit in this spectrum? Where do you fit in? Where do you draw the line between disabled and non-disabled? And consider something obvious, something many of you immediately noticed. Stephen Hawking is widely considered one of the great geniuses of our time. So if you're talking about the body-mind, his mind is extremely able. So then where does that place him on this spectrum? I'm not comparing his intellect with that of LeBron James. When you talk about all the ways in which humans are unique and marvelously different, you realize that the makeup of our body-mind is so complex that assigning people a location on a spectrum is impossible. And of course, it goes without saying that a person's worth is not related to their ability or disability. Humans have an intrinsic value of their own. But for now, this is what we're dealing with. These are photos of the Berlin Wall. On the left is Attorney General Bobby Kennedy in West Germany, staring over the wall into East Germany. And on the right is another photo, again showing the division. And people perceive this sort of hard separation between the disabled and non-disabled, between the stigmatized other and the quote unquote normal. You could also draw another analogy from the wall with able-bodied doctors on one side and sick patients on the other. But again, this analogy also breaks down. This is just a small smattering of doctors with disabilities who are practicing and succeeding in their field, not in spite of their disability, but also because of their disability. They're doctors and sometimes are also patients. Even the audience might feel alone with your disability. You may fear that there's no one else like you, but stories are a powerful force for change, and people are telling their stories. And this is what needs to happen. This is a photo of Germans tearing down the Berlin Wall in 1989 at the end of the Cold War. In functions like this, in the work that we are doing, in the stories that you tell, we are taking sledgehammers to this wall, and we are tearing down the wall of ableism. The work is hard and it's slow, but we are gradually changing the culture of medicine. It's important to make a difference between non-discrimination and inclusion According to the WHO, the principle of non-discrimination seeks to guarantee that human rights are exercised without discrimination of any kind, based on many protected factors, of which disability is one. This is epitomized by sayings such as, "We are an equal opportunity employer." Non-discrimination to me means following applicable laws to avoid legal liability. It's walking the line between protecting employees and protecting the institution. Inclusion, on the other hand, means actively recruiting, retaining, and mentoring students and employees, healthcare providers with disabilities, and doing everything we can to optimize their access and experience. As Elisa Laird said at the Coalition Symposium, we must abandon a compliance-focused approach. What do we have to do? And move toward a justice-centered approach. What can we do? And I ask you in the audience, who do you want to be? Do you want to be a leader in disability inclusion, or do you seek to simply not discriminate? Oops. With that, here's a group of parachutists flying through the clouds, holding hands, and let's dive in.